Hi, I'm Kathleen Digre. I'm a distinguished professor of neurology, and I am the division chief for headache and neuro-ophthalmology. And I'm so glad to be with you today to talk about, I have daily headaches. What are my options for a reset? So I'm going to start with a case. This is Sharon. She's a 40-year-old woman. She has a family history of migraine, and her migraine started at the time of her menstrual cycle starting. And then she got married and she had 3 children, and their migraine became much more frequent. Then the last 2 to 3 years, she's been having almost daily headaches. She's currently taking Prozac due to depression. She's been on topiramate because she wanted to lose some weight and prevent her migraine. And she's had a sumatriptan. She used to take just a half a tablet, and that would take care of the headache. Now she has to take 4 full tablets, take half a tablet 4 times every single day. And in between, she's using Excedrin and ibuprofen, and she kind of trades these off, hoping that one will work, but she often wakes up with a headache and she's asking, what can she do? So the first step when somebody has so many headaches is to say, what's causing these? These headaches are throbbing. She has light and sound sensitivity. She has nausea. The bad ones are occurring 3 to 4 days a week. And in between, she has what she calls regular headaches, but they also have light and sound sensitivity, and it frequently goes into the bad migraine. So she's got migraine all the time. Her sleep is disrupted, and her husband says she snores. Her migraine now has become chronic, and we're going to talk about factors that make people have so many chronic migraine headaches. And then the next question is, does she have medication overuse? But what can she do to get out of that? Because she says, I've tried everything. So I think it's really important for anybody with migraine to know what are the factors that you can have some control over in going from an episodic migraine to a chronic migraine, which gets into that complete locked in state of chronic migraine. The first is medication overuse. So we're going to spend some time on that because it's so important and so frequent. The second is how frequent the attacks are, because if the attacks are frequent, it's much more likely that somebody is going to go into chronic migraine. How well the acute treatment works. Now, if ibuprofen works, great. But if it's not working, we've got to find something that knocks that headache out right at the beginning. Nausea. If there's frequent nausea, this also is a predictor of going into chronic migraine. Other factors include obesity, stressful life events, and certainly we've been living in a very stressful period of time now. Snoring, sleep apnea, and sleep disturbance. These are really difficult factors that send people into these really chronic migraine headache situations. And then depression. And the thing about depression is that it's co-linked with chronic migraine and migraine. And, people say, well, I wouldn't have depression if I didn't have these migraines. I go, well, you wouldn't have the depression if you wouldn't have migraine if you didn't have the depression. These are linked together. And it's almost a dose response curve. The more depressed you have, the more headaches you get, and so on. So it's really an important factor. There are some factors that we can't change. We can't change easily our gender, or the fact that we have migraine history, or our socioeconomic status, or the fact that we've had a head injury, even though these are also factors that can lead to more chronic migraine. So does she have episodic migraine or chronic migraine? Well, you would know just listening to this, she's having a migraine-like headache more than 15 days a month. So she has chronic migraine. And she's using a lot of medications. I counted up each of those half tablets that she's doing, and that amounts to about 16 sumatriptan tablets every month and 16 days a month of taking sumatriptan and ibuprofen 20 days a month. Now, she's using evidence-based acute therapies. And you can see that there's some over-the-counter things that have evidence base, some non-specific medications for acute migraine, but we call the migraine specific therapies. We've got the triptans is a migraine specific therapy. Dihydroergotamine is a migraine specific therapy. And now we have two new acute therapies, the gepants, rimegepant, rebogepant, and atogepant, as well as a ditan, lasmiditan. So these are all migraine specific therapies that have good evidence for use, but they're not working. So why do good therapies fail? Well, sometimes the wrong diagnosis is there, or an incomplete diagnosis, or the person has too many headaches, or the individual is in medication overuse like Sharon is, or there are multiple trigger factors. There can be the fact that there's not an adequate drug dose. For example, some people really need a full dose of a triptan, not a half dose. And then compliance. Are people taking the medication when they should? And sometimes non-pharmacologic therapies aren't completely adequate. And then our expectations may be really high, like we want that headache to be completely gone, and it may get better, but it may not be gone. And then, as I said, there may be these comorbidities that make things worse as well. So the first question is, how many of these medications is too many? Because it will lead to what we call medication overuse headache. And this ends up giving people a kind of a chronic migraine with medication overuse. And you can see the numbers. If you're on an ergotamine more than 10 days, triptans, an opioid, or even a combination analgesic like what Sharon has been on, or any combination more than 10 days, and she's been on both triptans and a combination analgesic, then she's definitely over the mark, and so she's got medication overuse. So she has medication overuse headache because she is overusing it, and I think it's contributing to the chronicity of her headache. The other thing is how many is too many, because it'll push you into the chronic migraine state. And again, this takes fewer per month to get you into chronic migraine. Opiates, 8 days a month. Barbiturates, like what's in Fioricet, Fiorinol, 5 days a month. Triptans, 10 to 14 days a month. Analgesics with caffeine, like Excedrin, more than 10 days a month. And sometimes anti-inflammatories like ibuprofen can be more protective. So Sharon says to me, I'm between a rock and a hard place. What am I supposed to do? I have to work. So when the migraine gets worse, I take more medication. I take more medication and the migraine gets worse. What am I supposed to do? So how do you get out of medication overuse? That, I think, is an important part of this. How do I reset from a daily headache to a less frequent headache? Well, one way to do it is to stop what we call cold turkey. That means you stop all these acute medications at once and change it up and take something different and start a preventative therapy. So that's one way to do it. Another is to start a preventative and then come off the acute medication as well as you can, plus change that acute medication. We'll talk about some medicines that may be less likely to give so much medication overuse headache. And you can just taper off the acute medication and hope that the overuse headache goes away. And sometimes you can substitute a medication that doesn't cause a medication overuse headache. So we recently finished, and the University of Utah was a partner in a large multi-center trial called the Medication Overuse Treatment Trial, or MOTS trial, that found that you can either stop cold turkey and start a preventative, or you can start a preventative and come off the acute medications. So either way will get you to the right place. It was also found that some people had a lot of anxiety over just stopping their acute overused medicine. And so maybe those people should start the preventative and then slowly come off the overused medicine. Now, I think it's really clear if you have daily headache, you need to be on a preventative. Because obviously, if you have a daily headache, it's interfering with your life. And if it's more than 2 days in a week, it's interfering with your life. And if you're in bed more than 2 days in a month, it's interfering with your life. And if you can't take an acute medication to stop the migraine headache, then it's interfering with your life. And then if you're overusing acute medications, we've got to get you on something for prevention. So prevention is really a critical piece of migraine treatment. So what's the goal of prevention? Well, the goal is to decrease the attack frequency at least by 50%. Now, it may mean that they're not completely gone to start with, but if they're gone or reduced by 50%, that's a whole lot better than what having them every single day. And then that preventive therapy can improve the acute treatment success, and it can reduce our recurrence rate, and it can prevent medication overuse, and it can improve function and reduce disability. And it decreases what we call presenteeism. That means you go to work, but you're kind of like fuzzy in your brain and you really can't think and you really can't work. So you're really not working optimally. And our bosses don't like that, but also they don't like us missing work either. So preventive therapy is critical. If you've got chronic headache, you need to be on a preventive therapy. Now, fortunately, we've got so many great preventatives now to use. For years, we've relied on the anticonvulsants like divalproex sodium or topiramate. We've relied on beta blockers like propranolol. We don't use the pesticides right now, the butterbur, because of some preparation errors that are ongoing, and we are waiting for this to be rethought out. An ACE inhibitor like candesartan is also a good preventative. But there are some migraine-specific preventatives that are really excellent treatments for preventing migraine. And these are the CGRP monoclonal antibodies. There's arinamab, fremanezumab, galcanezumab, and eptimizumab. And you may know these as Amavig, Ajovy, Emgality, and Yavepti. And then there are GPANTs, and there's that can be used as a preventative, and were actually approved by the FDA as preventative, Ramigipant and atogepant. Now, there are many other very effective medications. Some of these are so old, there were not really good trials to make them grade A evidence, but they're still really helpful for so many people. Some of our antidepressants like amitriptyline and venlafaxine and other beta blockers, some nonsteroidals. We often will use the longer acting triptans for some short-term prevention around menstrual migraine. And then there's some herbal vitamin preparations that have also been shown to be probably effective. And then possibly effective, there's some other medications as well. So Sharon says, so if I start a preventative, what can I take for my migraine headache when it occurs? So we said, let's put you on a longer acting triptan. And there are two of these, frovatriptan and naratriptan. And that really can work very, very well for a lot of people, rather than the shorter acting triptans like sumatriptan. The other possibility is to put her on a different class of drugs. For example, the new GPANTs that are just CGRP blockers, and ubrogepant, ramigipant, and atogepant, or a ditan. This is a similar to a triptan, but it causes extra drowsiness, but it does not constrict coronary artery vessels. And then I like medications that don't cause rebound. For example, the phenothiazine. One of my favorites is promethazine, but prochlorperazine, which is also known as compazine, and chlorpromazine, which is known as thorazine, can be helpful. Metoclopramide also can be very helpful, and none of these are going to cause medication overuse. I also really like hydroxyzine, and we have devices. So these devices can be there so you don't even have to take a medication at all. And there's the supraorbital nerve stimulator, which is an acute and preventative um, method, and this is called the Cephally device. Then there is a vagal nerve stimulator, which is transcutaneously. This is gamma core. Then there is a transmagnetic stimulator that stimulates the brain with magnetic waves that can stop a migraine. Then there is the peripheral nerve stimulator that is on the arm, and this can be used acutely, called Nerivio. Now there is a new stimulator that stimulates both the front supraorbital nerve and the occipital nerve, and this is called Relivion. Now, Sharon says to me, does this mean if I can get these headaches gone, I am done with medication overuse headache? Well, the problem is that most people will have an initial success rate of about 72% with a 50% reduction in headache days. But it's a slippery slope to go back to, because some people get back on their medications, and within that first 12 months, if they go back, they can get it back. And the best thing is we want to prevent medication overuse headache. So Sharon comes off her daily medication. Her headaches are reduced by at least half, but she's still having chronic migraine. And so she goes, what else can we do? And so we don't want to forget some of the very basic principles in migraine, and that is the importance of education. And that means that everybody who has it says, I'm in charge of this headache. It's not in charge of me. So that I am going to establish my own self-efficacy. I'm going to be in charge of this. And then I'm going to be in charge of reducing my medication overuse and treating my rebound or avoiding rebound. Smoking is another factor that can make headaches worse. So if you smoke, you want to stop smoking. Eating regularly is really helpful for many people. Some people who fast can just guarantee that they're going to have a migraine. Sleep is critical, and I'm going to talk more about sleep, but getting sleep at night is where your brain gets rid of all the bad chemistry and is really critical for getting migraine under control. Caffeine can be another thing to be watching out for. We recommend no more than 12 ounces a day of a caffeinated beverage. And I think that sometimes is hard for people to follow. And sometimes the caffeine has sweeteners in it, and some of those sweeteners can also create migraine. We also recommend daily exercise. Not only is it good for your mental health, it's good for your physical health, and it's really good if you can get out and exercise to prevent migraine. And then stress management. We live in an extremely stressful world, and we know that stress isn't the cause of migraine, but it makes it worse. So the more that we can get that stress under control, the better. So what I always say to everybody who has chronic migraine, let's work on all the modifiable factors. Like if you're obese, let's work on weight loss, nutrition, and exercise. If we've got too many headaches, let's work on preventive medication and then some behavioral strategies. If there's a lot of stress going on, and who doesn't have it, we all need more mindfulness and stress reduction techniques. If there's sleep disturbance and snoring, we need to work on making sure that somebody doesn't have sleep apnea and work on sleep hygiene. And sleep hygiene means sleeping 8 hours every single night and not doing other activities, and certainly not being online or using a computer or some kind of device right before bed. If there's depression and anxiety, this needs to be treated, because this, remember I said, is another factor that can make migraine more chronic. And then if there's a lot of caffeine use, we can taper off or stop. I want to put a plug in for what we call cognitive behavioral therapy. This is a certain kind of therapy that allows people to really delve into what kinds of things seem to trigger you, what kinds of things seem to get you off out of control. And this is extremely important because it means that you can have more control for yourself. And then we want to limit all the acute medications. I said sleep is critical. If you don't sleep, it's really hard to get better. And there's many reasons why people don't sleep. One is they can't turn their brain off and their brain just keeps on going and going and going. And there are ways to turn people's brains off. The other is very stressful life experiences keep us up worrying all night long. Many medications and drugs can actually make us not sleep well at night. Caffeine, for example, and alcohol, while it may make you sleepy at the beginning, it will frequently disrupt your regular sleep patterns. Snoring can be related to sleep apnea and can make headaches worse. And sleep by itself, we always use sleep as kind of a way to reset your receptors and stop the daily headache. In fact, in the old days, sometimes we would just put people to sleep for 3 days and get as a reset to get out of that chronic migraine state. I've already mentioned cognitive behavioral therapy, and in some studies, it's been shown to be almost as good as a preventative medication. Wow, that's like really important, isn't it? And I think the combination of a preventative medication and cognitive behavior therapy is really powerful. And we found this out in the children's study looking at migraine in the CHAMP study. And it really works best for episodic migraine or less than chronic migraine, but it still works for people with chronic migraine. And then there's a whole bunch of these related therapies like a relaxation based therapy, mindfulness based treatments that have been studied and shown to be helpful, hypnosis and self hypnosis, and even these immersive virtual realities for acute pain, migraine, and headache have been found to be helpful for certain people. So don't discount cognitive behavioral therapy and its allies. Now, on occasion, we use some medications to break a migraine cycle. This is kind of like, how do you reset your whole brain? And sometimes this requires that a person may need to go into the hospital or an infusion clinic. Rarely it can be done at home. But if you come into a hospital, sometimes we will treat you with a medicine that stops the nausea, and we use dihydroergotamine IV for 3 to 5 days. We also have used intravenous neuroleptics like chlorpromazine or Thorazine IV, or prochlorperazine or Compazine IV, or metoclopramide or Reglan IV, or droperidol IV. Sometimes we use an antiemetic and ketorolac just as a shot in a clinic. Often that's not enough to completely reset somebody who's in a really strong chronic migraine state. We've also used steroids like dexamethasone or methylprednisolone to try to reset the brain cycle. We've tried magnesium IV over 20 minutes. We've used IV Depicon or Valproate with good success. Promethazine in conjunction with hydroxyzine has been used. In some pain clinics, IV lidocaine has been used to reset the cycle. And then there are ketamine infusion clinics that have been used to try to reset the brain in a pain cycle. So these are IV, mostly intravenous therapies that are done either in the hospital, infusion clinics, sometimes pain clinics, rarely in the home. Now, these super refractory patients really need to be seen by neurologists who are experienced with taking care of headache patients or headache specialists. And if hospitalization is required, there are many reasons for bringing somebody in. One is that the symptoms are so severe and refractory that outpatient treatment has just not worked. Many have drug overuse or toxicity that can't be treated as an outpatient. We sometimes need intensive neuropsychiatric or behavioral comorbidity treatments that, that are very important and could be done as an inpatient. Some people may have confounding medical conditions that make it hard to treat as well. And then some people are just desperate, and bringing people into the hospital and trying to get a handle and stop this daily cycle can be really helpful. During that time, we may use infusions like the ones I talked about. We may use cognitive behavioral therapy. We may set people up to be in a multidisciplinary headache clinic or a pain clinic. Rarely we send people for surgery. In the Choosing Wisely initiative that went out to all physicians and providers, surgeries outside of a clinical trial should not be done. But there are some surgical procedures that have been done. Now, I want to bring up some special considerations that may be important to you or somebody near you. One is adolescence. So, chronic daily headache in adolescence is not common, but it does occur. And the worst problem is that these kids don't get back to school. Interesting, there's very little medication overuse. And these kids can go from episodic to chronic migraine just in a very short period of time. Depression is key to scan for in these kids. Just imagine, remember yourself in adolescence, that not only do you have the genetic predisposition, maybe a family history of headaches and maybe a family history of anxiety or depression, then you're going to school where you've got teachers and grades and friends and maybe bullying. And then your environment may not be the healthiest. There may be lack of sleep. You might not have a regular diet. Your activity level may be disrupted. And then in the family dynamic, there may be a divorce situation or substance abuse or a blended family. And maybe some families just don't have a lot of resources. And then that couples together to give stress. And this is really a critical understanding of adolescent headache because these kids are vulnerable. Frontal lobes don't work so well, and depression can be deadly. So it's really important to recognize daily headache in adolescence. There's another kind of headache that's really difficult, and that is a continuous pain on one side all the time, never going away, with episodes of sharp stabbing pains. And we call this hemicrania continua. But the good news is it does respond to indomethacin. But it is a kind of daily headache that sometimes people don't recognize. And it's important, if you feel you always have a unilateral side locked headache, you should talk to your provider about this possibility. Another headache that's really difficult is a headache that starts one day and never leaves. On October 12th, 2021, I had a headache come on and it never left me. Well, most people with this headache give me an exact date and time that the headache started and it never went away. These headaches must be evaluated extensively to rule out a secondary cause, because low pressure can cause this, high pressure can cause it, meningitis can cause it. There is a whole host of things that cause new daily persistent headache. It's frequent after flu or after infections. And we're seeing this now after COVID, SARS-CoV-2. It's usually continuous and it's very difficult to treat. And on this graph, you can see that it can happen in women in the black bars and in men, and it can happen over the lifespan. But usually it's in these less than 40-year-olds will start with this headache. It's one that your doctor needs to take seriously and try to come up with better treatments for. Now, I want to leave you with some resources besides our headache school that you can attend once a month, the second Tuesday of the month. The American Migraine Foundation has a free newsletter. It has up-to-date information for patients. There's a Facebook page, group page, and there are many other resources that can be found. On our University of Utah Headache Clinic website, you can download a whole booklet on headache on all the medications that are there. And I encourage you to learn as much about migraine as you can. If you have migraine, do it for yourself. Do it for your family, because many of your family members may have this as well. And these daily headaches are really problematic, but there's hope. You can reset your brain. And I hope this talk and Sharon reset her brain and got her headaches into episodic migraine at the end and felt much better. I'll leave you with this picture of the patron saint of migraine, which is Saint Dymphna. And she is treating this young lady with an experienced rabbit and some vapors to stop her continuous migraine. Thank you for your attention, and I hope we can have some questions.